Dear colleagues, ladies and gentlemen, welcome to today's European Association Cardiovascular Imaging webinar on EACVI expert consensus paper on the use of lung ultrasound in acute and chronic heart failure, which has been just finalized and will be submitted for publication very soon. I'm Aleksandar Nešković from the University Clinical Hospital Center Zemun in Belgrade, and I have the great pleasure of being joined by two experts who participated in writing of this paper, Dr. Marcelo Migliorance from Institute of Cardiology, University Foundation of Cardiology in Porto Alegre from Brazil, and Dr. Luna Gargani from University of Pisa, who was the leading author of the paper. So the aim of this webinar is to give you a better understanding on how to use ultrasound in the management of patients with heart failure through a couple of presentations of clinical scenarios where lung ultrasound might have added value in diagnosis and treatment of heart failure. The session is intended to be interactive, and we strongly encourage you to actively participate in sending our comments and questions at any time during this webinar through the chat. And for the best learning experience, we also invite you to participate in online assessment sessions in the form of multiple choice questions that will be submitted during the presentation. And I will now hand over to Dr. Marcelo Migliorance for his presentation. Marcelo.
Thank you, Professor Nešković. So in the next minutes, we talk about the application of lung ultrasound in acute heart failure setting. This is my disclosure. So acute heart failure is a main importance in our clinical practice. And I have no doubt to say that the differential diagnosis of acute dyspnea is very challenging in our practices. So, acute dyspnea usually is the main reason for our emergency consultations. And for that, we need to have different informations to perform the right diagnosis in the right time to treat these patients. We have here a typical case of acute dyspnea. It's a 68-year-old man with multiple comorbidities. He is a smoker, have copped systemic arterial hypertension, and a prior history of STEM. He complains of acute and progressive dyspnea with a NIHA class 4. He also complains of productive cough. And during the clinical examination, presents with lower extremity swelling and diminished breath sounds. So, we have different hypotheses for this acute dyspnea etiology. Usually, we start the evaluation with a chest X-ray. In this case, we can see a typical cupped chest X-ray with a rectified diaphragm, and also this patient have enlarged heart area. The EKG does not help us too much. This presents a left bundle branch blockage. What the literature says, that most of these patients with no obvious cause of dyspnea has about 50% probability of left ventricular dysfunction. But usually, our physical examination is very limited in an emergency setting. And also the chest X-ray could not be helpful, mainly in patients with previous chronic heart failure. Laboratory tests also could not be available and sometimes are very time-consuming. And we need a rapid therapeutic decision, so a rapid diagnosis. Usually, we try to get as much as possible information about this patient, combining different evaluations with physical examination, chest X-ray, ECG, and NT-proBNP. And our overall clinical impression of these patients usually have just 4.5 of positive look-alike ratio. So how could you have more information to perform a proper diagnosis of these patients. We could go on performing a lung ultrasound evaluation. In this patient, we scanned both hemithorax and found this typical imaging. So, what is the most likely diagnosis for these patients? 1. Pneumonia. 2. Pulmonary embolism. 3. COPD or emphysema. Pneumothorax. Or 5. Acute heart failure with cardiogenic dyspneas as etiology.
Okay, we are waiting for the answers of the audience.
So
now
I'm showing, I'm showing again the typical imaging that we found in the
50 people actually voted, and there is the majority of them said COPD and emphysema. So what would you say, Marcel?
Yeah, actually, this is a very difficult diagnosis of this type of patients because these patients usually have multiple comorbidities, and it is difficult to determine what is causing this dyspnea. But using all the information we have with patients and using mainly the lung ultrasound in this case, what we are seeing, a typical imaging of B lines presented in both hemithorax in multiple sites, and in each site we have more than 3 B lines. So in a clinical picture like that, our diagnosis most probably is acute heart failure. This patient was admitted, and the echocardiogram confirmed severe systolic LV dysfunction with an ejection fraction of 27% and a EE prime ratio of 18. His NT-proBNP also was very high, 2,460. And he had no alteration in white blood cells count. As we can see, we have different studies about the application of lung ultrasound in critical care scenario, and mainly for differential diagnosis of acute dyspnea. This was one of the first applications of lung ultrasound. And this meta-analysis demonstrated that the overall sensitivity and specificity of a B-lines pattern bilaterally in a patient have around 94-92% of sensitivity and specificity respectively. So it's a very accurate method. And this meta-analysis comparing lung ultrasound with chest X-ray, we realized that lung ultrasound has a higher sensitivity and equal specificity of chest X-ray. And why is that? Because mainly these patients with chronic heart failure, they have a basal alteration in chest X-ray that makes it difficult to perform a diagnosis of acute heart failure decompensation. So, now we will see what happens with this patient. The second part of this case is this patient admitted to ward. He received diuretics, vasolators, and all his medications was titrated. He lost about 6 kilograms, probably related to fluid overload. He referred a dyspnea relief, and also the peripheral edema have reduced. So, what is the time of hospital discharge of this patient? It's a very common doubt during our class. Can we safely discharge this patient? 1, yes, the patient appears to be compensated. 2, No, the patient remains decompensated. 3. First, I would like to do a lung ultrasound. 4. Yes, if the clinical evaluation is normal, despite the lungs ultrasound evaluation and findings. And 5, no, the patient needs more diuretics.
Please vote.
Usually in these patients, we perform a clinical evaluation day by day, and using mainly the pulmonary auscultation and the evaluation of peripheral edema. And we now should rethink about our practice. Maybe include more information could help us to perform a more reliable evaluation and be more secure when perform the discharge of this patient.
Okay, we have results. The majority of the audience voted for 3. No, first I would like to do a lung ultrasound. So already learned something, I suppose.
Yeah, that's pretty great. So we performed lung ultrasound in this patient before his discharge. And we saw in all lung fields, bilateral, this other type of imaging. This type of image is what we call an E-line pattern. It's the normal oriented lung pattern. So we could discharge this patient with security, knowing that he will have a good follow-up. The literature has demonstration through different studies, and here I highlighted the most important ones, one performed by Dr. Luna Gargani and another about Dr. Corey, and highlighted the role of residual extravascular lung water. What it means? That usually these patients have subclinical degree of extravascular lung water that we cannot identify using our traditional tools. And when we use lung ultrasound and we detect before discharge a residual degree of congestion, this patient will have a worse outcome. So we need to remain with this patient in our hospital and titrate a little bit more the medications before discharge. And this is also highlighted by the latest ESC guidelines.
Thank you, Marcelo. This was a really nice brief introduction in the use of lung ultrasound in acute heart failure. Now I'd like to ask Dr. Gargani. Luna, can you tell us something about the use of lung ultrasound in chronic heart failure?
Okay, so thank you very much, Sasha, and it's my pleasure to be here. This is my disclosure. So we are differentiating the use of lung ultrasound in acute heart failure and chronic heart failure. Marcelo explained us how to better use lung ultrasound in patients with acute heart failure, but there are also some very interesting applications in chronic heart failure. And here with chronic heart failure, we mean outpatients with a known diagnosis of heart failure. And I would say that the main application of lung ultrasound in this population is the help in guiding diuretic therapy during follow-up. So let's see how to implement this in our day-by-day clinical practice. So we have this case of an 81-year-old woman. She has a hypertensive heart disease. She was admitted for a heart failure with preserved ejection fraction 9 months ago. And now she's coming to your ambulatory office for the regular out-of-office heart failure visit. So it's a regular visit. She's actually stable. When she comes to you, she says she has a dyspnea class 2, which for this patient means to be stable. I mean, the patient says that she's rather asymptomatic. This is her kind of dyspnea since the last 10 years. So she feels stable. She has no signs of heart failure. She doesn't have any NT-proBNP values, so she was asked to bring some lab tests. She had some lab tests, but no NT-proBNP, and this happens quite often in our outpatients. So we ask for some tests, but not always they bring what we ask and what we would like to see. So we perform an echocardiography, and we can see that we have quite a significant left ventricular hypertrophy, concentric left ventricular hypertrophy. The ejection fraction is preserved, and we have a significant dilation of the left atrium. So quite a consistent picture for patients with heart failure with preserved ejection fraction. If we check the diastolic function, we can see that there is impaired diastolic function. Ion A is 1.65 with Ion E prime of 20, so it is quite elevated. The pattern of the pulmonary veins is not so bad, but we have an overall picture of increased left ventricular filling pressure as non-invasively assessed by echocardiography. We also have data from pulmonary artery systolic pressure, and we have here a slightly increased pulmonary artery systolic pressure. The maximum velocity of the tricuspid regurgitation is about 3 meters per second. The inferior vena cava, which is also very important to be checked in this patient, is 19, which is considered a normal value. It's almost high normal. But with normal respiratory variation, so we add 3 millimeters of mercury, and we have an overall estimated pulmonary pressure of 40. So we do an integrated cardiopulmonary ultrasound in this patient. We just move the probe from the heart to the lung. We don't change the setting, and we assess the lung. We see this picture. This is a summary of the exam. Usually we use 8 scanning site scheme, so we would have like 8 videos, but this is a comprehensive summary of what we see in this patient on both hemithoraxes. So please take some time to give a look to this lung ultrasound exam, because we have our first multiple choice question on this exam. Okay, so this lung ultrasound exam is showing no B-lines, multiple diffuse bilateral B-lines, a bilateral pleural effusion, B-lines on the right hemithorax, but not on the left hemithorax, or a consolidation consistent with pulmonary infarction. We know that we can assess also consolidations by lung ultrasound. So just give a look again to the 5 multiple choices. You can vote now, and we can give a look again to the picture. Okay, so let's wait a few seconds to have the answers. Again, these are the choices here. 1, 2, 3, 4, 5.
It's just a couple of seconds more.
Yeah.
Now we have the majority of the audience voted for 2 multiple diffuse bilateral B-lines, 75%.
Good, good. So I'm very happy about these answers, because actually this is the correct answer. This is a picture of multiple diffuse bilateral B-lines. So multiple means that we have at least 3 B-lines in a single scanning site, but usually when we have significant congestion, we have even more than 3. As in this case, we have quite many B-lines. Then diffuse means that you have significant B-lines in at least 2 scanning sites on the same hemithorax, and then you have it bilateral. So this is the lung ultrasound pattern of cardiogenic dyspnea of extravascular lung water. So actually, this patient has a subclinical pulmonary congestion, and we know very well that there is a window, a time window in which patients with heart failure can be asymptomatic or oligosymptomatic, as in this case, during which they develop pulmonary congestion, and then suddenly they become symptomatic and they may require hospitalization for intravenous diuretic therapy. So it would be ideal to see these patients which are flying under the radar in this time window while they have pulmonary congestion, but they are still asymptomatic. So in this case, it may be indicated to increase the diuretic therapy in these patients, and we will see then why it can be a good idea. Okay, so we have another case now, a very similar scenario. We have now a 61-year-old man with chronic ischemic heart disease. He was admitted 3 months before for an episode of heart failure with reduced ejection fraction. And he also is coming to your ambulatory office for a regular visit. As the same of the other patient, he has no sign of heart failure, and also dyspnea can be estimated in NIA class 2, but also for these patients, NIA class 2 is felt quite as a good symptomatic status, so the patient refers to feel stable, nothing new from the symptomatic point of view. This patient has some NT-proBNP exams, which is 365. So this patient as well of the other patient both were on top of optimal medical therapy. So let's see the echocardiogram. We have a moderate reduction in the ejection fraction, and you can see that there are some regional wall motion abnormalities in the territory of the LAD. This was a patient with chronic ischemic heart disease. He had a previous myocardial infarction. The left atrium is mildly dilated. Let's give a look to the diastolic function. And again, we find signs of clearly impaired diastolic function. We have an EONA of more than 2. The EONA prime is increased. It is 16.5. We also have here S less than D in the pulmonary veins pattern. And we have a slightly increased pulmonary systolic pressure. It is estimated as about 36 millimeters of mercury, again from the value that we obtained with the modified Bernoulli equation from the maximal velocity of the tricuspid regurgitation, and the inferior vena cava, which here is very similar to the other patient, 18 millimeters, so a value that is considered normal. And this patient also had normal respiratory variation. So we have final 36 for our estimated pulmonary pressure. But again, we do integrated cardiopulmonary ultrasound in this patient. So we perform a lung ultrasound at the end of the echocardiography. We don't change the setting again, just move the probe from the heart to the lung, and we see this picture. Again, this is a summary of the 8 scanning site scheme. So take some time to give a look to these lung ultrasound videos, because we have another multiple choice question now. So this lung ultrasound exam is showing no B-lines, multiple diffuse bilateral B-lines as in the previous patient, a bilateral pleural effusion, B-lines on the right hemithorax but not on the left hemithorax, a few B-lines at the right lung base. So you can vote now. I will show you again the picture. So this is our lung ultrasound. It's always useful, of course, to compare what you see at the more upper zones, so the apex of the lung, and the more lateral, lower zones of the lung. It is a very useful comparison because also the distribution of B-lines is informative in these cases. Okay, so again, let's see the potential questions.
Just a couple of seconds.
Yep.
So it's interesting, about 50% of the audience voted for the first, no B-lines, but significant number voted also for bilateral pleural effusion and B-lines on the right hemithorax, but not on the left hemithorax. So it is mixed.
Yeah, so I think these answers indicates that there is still the need in our cardiology community to learn some lung ultrasound, which is now much more used than before, but still it is not standard in every cardiology practice. So I think at least this can be a bit useful. Okay, so let's see, the correct answer here is no bilans. Let's see again the picture. So here you actually have in all the 4 videos, you see the pleural line. This is the pleural line with the normal lung sliding. You may see the A lines. The A lines are reverberation, horizontal reverberations of the pleural line and are present in the normal lung ultrasound pattern. And we see lines here, 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 and also here. So we don't have any vertical artifacts. We don't have any B lines. And we also don't have any pleural effusion, which would be displayed as the black area, as an anechoic area. Of course, also pleural effusion is part of lung ultrasound and is a very important information that we may get in these patients. Okay, so actually this patient was a patient, again, with a history of heart failure, with a slightly elevated NT-proBNP, no signs of HF, but actually no pulmonary congestion. So in this case, what we did not change the diuretic therapy. We kept on going like that because we didn't have signs of pulmonary congestion in this patient. So here we had 2 different patients with a quite similar situation, one with preserved, one with reduced ejection fraction, both with no signs of HF, both with dyspnea in NIA class 2. NT-proBNP is not so helpful because in one case we don't have it, and it's quite often that we cannot have it in chronic patients, in outpatients, or in some cases it is a bit in the gray zone. And echocardiography can helpful, but lung ultrasound here can really provide information about the pure pulmonary congestion. And we have data to base this approach. I mean, we can base this approach on at least 3 different randomized trial, all of them showing that if in outpatients with chronic heart failure, you integrate lung ultrasound and you guide your diuretic therapy also according to the lung ultrasound picture. And I would underline also, so we don't use lung ultrasound in isolation. We use it integrated with the physical examination, the NT-proBNP, everything that we have. We just add lung ultrasound. And in this overall integrated assessment, if we guide diuretic therapy in this way, we have a reduction in urgent visits for heart failure, in rehospitalization for heart failure, and also death. So actually we have quite solid data to act like this in the ambulatory office, do a lung ultrasound, and integrate this information to decide whether we have to lower, keep the same dose, or increase our diuretic therapy. And in the end, the main concept here is that if we do an integrated cardiopulmonary ultrasound, this is very powerful because on one hand, with echocardiography, you may establish the etiology of heart failure. And you also have very nice non-invasive hemodynamic information, so ionic prime, the pulmonary pressure, also the volume of the left atrium. But if you want the information of the pure pulmonary congestion, so of the extravascular lung water, you need lung ultrasound. So to establish the degree of heart failure, actually lung ultrasound can be really useful, probably more than echocardiography, which is a cornerstone, but for understanding how is the heart, how is the function of the heart. And this concept is linked to this proposed universal definition of heart failure. So from the group of John Cleland in Glasgow, the proposal is to define heart failure when you have a cardiac dysfunction, of course, but together with the presence of congestion. So you need an evidence of congestion to define heart failure. And of course, you can define congestion in many different ways. You can also assess congestion in many different ways, but you need congestion with a cardiac dysfunction to define heart failure. Lung ultrasound is a very quick and easy method to assess congestion together with a cardiac dysfunction if you do an integrated cardiopulmonary ultrasound in your patient with the same probe in the same examination. And we should also remember that we have different types of congestion. So in our patients with heart failure, when we have increased left ventricular filling pressure, we can talk about hemodynamic congestion, which is what also provides the rise in NT-proBNP. But to move from hemodynamic congestion to pulmonary congestion, we have a lot of other parameters, such as the hydrostatic pressure, the oncotic pressure, the permeability, the lymphatic drainage, the alveolar capillary membrane integrity. So a lot of different parameters that can determine different degrees of pulmonary congestion for the same degree of hemodynamic congestion. And then you may have also different degrees of systemic congestion and clinical congestion, so presence of JVD, of leg edema. And again, you may have, for the same degree of pulmonary congestion, very different systemic and clinical congestion in your patient. So we have different congestion and we need different ways to assess congestion. Lung ultrasound is a way to assess purely only pulmonary congestion, so extravascular lung water. Okay, so we have another very interesting clinical scenario when we can apply lung ultrasound in our outpatients, and it is stress echocardiography. And again, we have very solid data here that if you have an increase in B-lines, so if you develop B-lines or increase your number of B-lines during stress, especially during exercise, these B-lines can stratify your prognosis quite strongly in terms of mortality and all cardiovascular events. And this is true both in heart failure with reduced ejection fraction, but also in heart failure with preserved ejection fraction. So again, here, for example, if you have a delta B-lines more than 10, so if you have a change in the number of B-lines more than 10 between rest and peak exercise, you can see that this can predict with a good accuracy new events. And even better if you integrate delta B-lines with other variables, such as NT-proBNP, the oxygen consumption, the DE on VCO2 slope on cardiopulmonary exercise test, and also the pulmonary artery systolic pressure in this integrated score. This score, again, performs very well in stratifying your population for heart failure hospitalization, cardiovascular death, and composite endpoints. Again, in outpatients, in this case, with heart failure with preserved ejection fraction. We have limitations, of course, as in every other test and examination. Some are related to the technique of lung ultrasound. It is ultrasound, so there is some kind of operator dependency, which is also a bit mitigated by the simplicity of the exam. The exam is really easy, especially if you just have to learn the lines. We have some limitations in obese patients. Very obese patients like class 3 obesity, it can be hard to do a lung ultrasound because you don't have enough depth of your probe to reach the lung. And also in patients who are obese, there is a relatively lower number of B-lines for the same level of congestion, which is actually the same that happens with BNP, natriuretic peptides, which is quite interesting, and we are still not sure why it happens. Then there are some limitations related to B-lines. We still don't have clear cutoffs. We still don't have only one scanning scheme, although we are moving towards a standardization with the 8-zone scanning scheme. And then there is a lack of specificity. So B-lines are not a specific sign of extravascular lung water. B-lines can be present in any situation where a partial deaeration of the lung is present. But if you have a strong clinical integration, if you monitor your patient, and especially if you integrate lung ultrasound into a multi-organ point-of-care ultrasound approach, this lack of specificity is extremely reduced. So, as take-home messages, in patients with heart failure, B-lines are the sonographic sign of extravascular lung water, so of pulmonary congestion, only this type of congestion. B-lines can be used for the diagnosis, for the monitoring, and for the prognosis of patients in both acute and chronic heart failure, and I would say in both heart failure with reduced and preserved ejection fraction. Integrated cardiopulmonary ultrasound can significantly improve our ability to establish the etiology on one side and the degree of heart failure on the other side. Lung ultrasound, in the end, helps us saving time. So this is the main message. What we can do with lung ultrasound is saving a lot of time to arrive to the correct diagnosis. And lung ultrasound guided therapy in heart failure patients improve prognosis. But don't forget, it's a clinical ultrasound. This is the quintessential clinical ultrasound, so it should not replace our brain, our medical knowledge, and clinical feeling. It's something we integrate with all the rest of our evaluation. And I would like to end by thanking all my colleagues and co-authors of this EACVI document, which hopefully will be soon released. We had a great journey together, and we hope that this can be useful for all the cardiology community and our patients. Thank you.
Thank you. Thank you, Luna. Thank you, Marcelo. This was really a nice overview of the topic, and I hope many from the audience will be interested to learn more of lung ultrasound in their future professional life. And we have a lot of questions, and I suggest if you want to go through them and try to answer to some of them. You agree, I suppose. There are some of them are technical and just brief. For example, what is the probe? What is the best probe to use? Can we use cardiac probe also? You mentioned something about it, Luna. You can just do it probably with the same probe as cardiac exam. Is it true?
Yeah, so for a cardiologist, the cardiac probe, of course, is the easiest one, but you can do lung ultrasound with any probe. So if, for example, you are in the emergency department seeing a patient for a consultation, they don't have a cardiac machine, you cannot do the cardiac examination, but maybe they have a convex probe, an abdominal probe, you can do the lung ultrasound with the abdominal probe. You can even use the linear probe, the vascular one. So any probes that you have at hand.
That's really excellent point. And another technical question was what is the optimal depth for a lung ultrasound?
Okay, so actually, if you want to use a general idea, it would be about 15 centimeters, I would say, between 12, 15, or sometimes...
Depending on patient habitus, I suppose, yeah?
Exactly, but it depends highly on patient habit. If you have a very thin patient, you decrease the depth. So even 8, 10 centimeters can be fine. If you have a very big patient, you may go to 20 or even more centimeters. As an average, I would suggest about 15.
And final, I think it would be also interesting to hear your thoughts about how many fields, how many quadrants will you use generally? Do you have some strict recommendation, or also it depends on situation or patient habitus? 2, 4, 8, 28?
Yeah, so
how does it, the good question is, how does it affect the sensitivity of the examination?
So this is a very relevant point. So first of all, we had different scanning schemes in the last 20 years of lung ultrasound literature. We are all trying now to use the 8 scanning site scheme, which means 4 zones per each hemithoraxis. Of course, in some situations, you may even reduce this scheme. For example, in exercise echocardiography, it is often used a simplified scheme with 4 scanning sites. You have 2 per side, about at the third intercostal space on the anterior and mid-axillary line, and that has proved to have optimal accuracy. The change, as you were mentioning, of course, can be in sensitivity. The less number of areas you explore, the less sensitive you are. And there is a paper showing that the 8 scanning areas scheme is the one with the highest sensitivity with the shorter time. But if you are really in a hurry, you can even do less. So what I strongly advise is always to compare apex with lateral. So actually apex with postophrenic angles and a bit higher, because the distribution of B-lines is also very important. In heart failure, you shouldn't see B-lines at the apex if you don't have in the more dependent areas. This would be a very strange pattern, raising the suspicion, for example, of a non-cardiogenic edema, for example, acute lung injury or acute respiratory distress syndrome. And in this phase of our lives, also raise the suspicion for COVID-19 pneumonia in the right clinical setting.
And that would be the way to differentiate COVID-19 pneumonia with acute heart failure, is it?
Yeah, this would be one parameter to differentiate by lung ultrasound. For example, we have a patient with dyspnea, with a chronic cardiac condition coming with dyspnea and desaturation, and you are not able to be sure if the cause of the desaturation and respiratory failure is the heart of the pneumonia due to COVID-19. If you have B-lines distributed in a non-dependent way. So again, you have B-lines at the apex but not at the base. And then if you have alterations of the pleural line, subpleural alteration, subpleural small consolidation, usually all these parameters are present in non-cardiogenic B-lines. In cardiogenic edema, B-lines are with a thin pleural line, homogeneously distributed, no consolidation. You can have pleural effusion. So it can really be helpful. Of course, again, you have to integrate in the clinical practice. Sometimes you have both together. If you have an overlapping heart failure and COVID-19 pneumonia, of course, you have both situations. So I don't know if Marcelo wants to add something on that.
I would like to ask Marcelo one question about acute dyspnea. So in acute dyspnea scenario, could we use just the lung ultrasound for etiologic evaluation?
So this is a very tricky question, because what we are seeing, most of people are learning to use lung ultrasound, and they are just focusing about lung ultrasound, and they simply miss to evaluate the patient and to put the findings in a clinical picture. So unfortunately, I can say to everyone that we need to use lung ultrasound as an extension of our clinical examination and integrate all the information, as Luna has said before. Just lung ultrasound, we will probably perform misdiagnosis and could do something bad for the patient. So please integrate the findings of lung ultrasound. And it's very, very important to perform a comprehensive scan, as Luna has said before. Despite performing 8 zones analysis, we need also to move the probe in this area to try to find the B-lines and try to look about the pleural line, because this information will make us able to perform the differential diagnosis.
Okay, then I would like to ask Luna or Marcelo, whoever wants to answer, about the added value of lung ultrasound B-lines over BMP. We know that BMP is something that we use for diagnosis and for prognosis. Is there some added value of B-lines over BMP?
Yeah, so probably I'll go first, and Marcelo, you can integrate. I think that the combined use of B-lines and BNP can be really powerful because, again, going back to the idea that we have different congestion, BNP is more a sign of hemodynamic congestion, whereas B-lines are just a sign of pulmonary congestion. And if we think about patients with heart failure, usually we have this concept of dry BNP. So we have that value of BNP that can be still elevated, but at which the patient is considered well compensated. But this value is very different from patient to patient and usually is not the normal value. I mean, if you have a patient with 30% ejection fraction, even if in optimal medical therapy, perfectly compensated, usually this patient doesn't have 30 of BNP or 50. He has a raised BNP, which is considered the good one, the dry one. For B-lines, what it is really useful is that if you are well compensated, your B-lines are zero. So there are no dry B-lines. It is zero or...
That is perfectly easy to obtain.
Exactly. Yeah. And again, you have the two information of hemodynamic and extravascular lung water.
And what about situation where we have elevated E to E prime? Is it possible to have no B-lines?
Yes, so as we have seen in the clinical case, you may have elevated E on E prime with no extravascular lung water. It is similar. I mean, you may have some degree of hemodynamic congestion, increased left ventricular filling pressure, but maybe you have a good lymphatic drainage, your alveolar capillary membrane works very well, and so you don't have extravascular lung water, you are on diuretic therapy. So again, in a patient with chronic heart failure, it's difficult to go back to a real normal, for example, E prime. But in these patients, you may have zero lines. So integrated all this information is really powerful because they see different aspects of the same problem.
Yeah, okay. Yeah, that's very important. And we need to keep in mind that we have some pitfalls when performing an E prime evaluation, like patients with very calcified beta 1s, we could have a false elevated E prime ratio.
So could we perform just a qualitative lung ultrasound assessment? I mean, presence or absence of multiple and bilateral B lines, or should we always semi-quantify the degree of intravascular lung water, Marcelo?
This is a very important question. As we have seen when Luna talked about different methodologies, some of our colleagues are focusing more in do a fast evaluation of the patients and try to link the lung ultrasound information with the clinical profile, but just seeing if the patient have multiple and diffuse and bilateral B lines. So they generally scan both hemithorax and found bilateral, multiple B lines. They said, okay, this patient have pulmonary congestion and should we administrate diuretics and vasodilators. So, okay, this helps us to perform diagnosis and the treatment of patients, but we miss a valuable information, that is the risk stratification of this patient. As we have seen from different studies, when we perform a semi-quantification of the extravascular lung water through B-lines counting or score-based number of fields, positive fields, we can classify if these patients with a higher or low risk of a bad outcome. So we encourage to perform a semi-quantification analysis. And also talking about the different methodologies, we have also presented an abstract in the ESC Congress comparing this 28 fields, 8 fields analysis. And also our study data in SAT showed that we have a good accuracy performing B-lines counting or number of fields positive, some score-based evaluation using 8 fields methodology.
Okay, the next question would be about integration of other parameters and B lines, for example, integration of inferior vena cava diameter or pleural effusion with B lines. Luna, can you tell us shortly about this something?
Yeah, shortly is really hard because we would need like one day. But in an extreme summary, inferior vena cava is a great parameter, but inferior vena cava integrates two information which are quite different from the line. So we have the intravascular volume and also the right atrial pressure. B lines, it's just extravascular water. So for example, you may have some old patients coming with acute heart failure and cardiogenic dyspnea and pulmonary edema, which are also dehydrated. They don't have much intravascular fluid, but they have a lot of extravascular fluid also in the lung. So in this case, you may have a not very dilated vena cava. Maybe the right atrial pressure is high, but there is low intravascular fluid. So vena cava is not so dilated, but you have B lines. So again, do everything, and these are very quick assessments because the information that they can tell you are different and can help you to titrate your diuretic therapy or sometimes give diuretics, but also, check also with fluids and have a more tailored approach to each patient.
About pleural effusion?
Yeah, and pleural effusion, of course, this is also a sign of congestion, of pulmonary congestion. But the dynamics of pleural effusion and B lines are absolutely different. So we can see a change in the number of B lines like after 20 minutes. Some patients, they develop during stress in 5 minutes, they go away in 10 minutes. So B lines are very, very dynamic. Of course, pleural effusion needs much more time to decrease and go away with diuretic therapy. So this is also a way to check how fast your patient is recompensating. And also pleural effusion is something that if we look at the echogenicity of pleural effusion by ultrasound, we may have a lot of nice information because you cannot do an etiology assessment. You need a paracentesis, of course, but sometimes we have these patients with pleural effusion where we have a lot of fibrin strand or pleural effusion is very dense. And in these cases, we should think about other causes which are not heart failure or concomitant causes such as pneumonia or cancer. So if you have a trasudate, if you have a pleural effusion due to heart failure, that should be black. If you start seeing dense pleural effusion, fibrin strands, complex pleural effusion, start thinking that the patient may have something more than not only heart failure.
Okay, now I have a question for both of you. How long do you have to learn to be confident in your lung ultrasound exam, at least for B lines?
So there is a very interesting study from the beginnings of the research of lung ultrasound performed in Pisa, in which they compared a medical student using a pocket-sized ultrasound machine and an expert echocardiographer using a high-end machine. And they demonstrated that after 10 studies, the medical student have the same accuracy from the expert. So it's a very easy to learn, and we can assure that for me it was quite similar because I was a student when I visited Luna in Pisa and learned in 2006.
Yeah, Luna?
I agree. I think you could need a couple of hours, 2-3 hours with someone who, expert is even not appropriate because, being expert in something so easy is strange, but someone who does the exam and knows how to do the exam, if it's only for the B lines, 2-3 hours are enough. If you want to learn also consolidation, pneumothorax, and other a bit more advanced lung ultrasound applications, you may need a bit more, but still it is a matter of a few days and probably between 25 to 50 complete examination, including all the different lung ultrasound signs, and you are absolutely an expert. Yeah.
Okay, just one really quick sitting or lying position, depending on situation, I suppose.
Yeah, there are some studies showing that there is a slight change in the number of B-lines when you change position. And I mean, it makes sense because water changes. It's not fibrosis, for example. So the advice is if you want to monitor your patient, which is what we want to do during admission for acute heart failure, just study your patient in the same position if you want to be really precise. But in the very end, you can do the exam in any position. I mean, especially for diagnosis, your patient can be even standing. That there is not a significant clinical change if you change position. Maybe a slight change in the number of B-lines, but the overall picture would not change.
Our information would be essentially the same, I suppose.
Yeah.
Thank you so much. We are now approaching the end of this webinar, and I would like to close this session by summarizing the key messages for your daily practice. So I think that recognizing that treating pulmonary congestion is a cornerstone in the management of patients with heart failure. And this is also clearly defined in the latest ESC guidelines, as Luna said. Lung ultrasound is easy to learn and to apply and can detect with high sensitivity pulmonary deaeration due to increased extracellular lung water. And it can be performed in parallel with comprehensive echocardiography and focused cardiac ultrasound using the same probe, with obviously great advantage in patients with heart failure. We believe that because of that, integrated ultrasound examination of the heart and lungs is likely to become a new standard in heart failure care, since it may be useful for understanding the etiology of cardiac diseases through the assessment of the heart and estimate the degree of decompensation to the assessment of the lungs, and to exclude other highly prevalent conditions that may mimic or overlap with heart failure, such as pneumothorax or pleural effusion. And also it can be performed using portable ultrasound devices almost anywhere in any setting where needed. So we do hope that you found this webinar informative and helpful for your practice. And I would like to thank both Luna Gargani and Marcelo Migliorance for their great presentations. You will be able to watch this webinar on demand on ESC 365 platform. And I would like to thank you very much all for your participation and attention. Thank you very much.
Thank you. Bye-bye. Thank you.
Bye-bye.